Morning, everyone, or good afternoon, good evening, depending where you are. Here in Canada is morning. I'm really happy to moderate this webinar, which is, which number is it, Martin? Our number 6, 7?
I don't know, I think it was number 11 almost, because we had 10 last year, 1 in January, maybe it's 12 even.
Great. So this is one of EUPSA web seminars, and it's on primary closure versus stage repair by silo and sutureless closure. And we have speakers that don't need an introduction. We have Professor Martin Lacher from Leipzig and Professor Nigel Hall from Southampton in England. So I think we all know Martin. Martin will kick off with the primary closure. Martin is the chief of pediatric surgery at the University Hospital of Leipzig, is the chair of the education office at EUPSA, and my usual co-host of these webinars. He has multiple interests in neonatal and pediatric surgery, such as colorectal surgery. But today we're talking about gastroschisis, and this is, of course, something that we all quite interested about. So without further ado, please, Martin, tell us a little bit how you deal with babies with born with gastroschisis.
So the postnatal management options you have in gastroschisis, you can reduce the bowel primarily, or you can place a silo as seen here, and then after a couple of days, close the abdomen. For the closure, you have 2 options. You can either do a suture closure, or you can do a sutureless closure. So this is what I'm going to talk about, the simple gastroschisis that is reducible. And in these cases, I do a primary reduction. If the bowel is not reducible, obviously you have to do a delayed reduction. Nigel will talk about that. And we all know there are cases of complex gastroschisis, and those need an individualized closing plan. So overall, like a lot of congenital diseases, gastroschisis is a spectrum. It is not the gastroschisis and not the one plan that works for all those children. So every child more or less has to be treated individually. Although I'm talking about the primary closure, of course, in the toolbox is also the silo that we use for other cases than the simple gastroschisis. So this is the typical postnatal management. I'm not sure whether you can see the video. I hope you can. We put a sterile or moist dressing after the delivery in a lateral positioning, preferably on the right, to avoid kinking of the mesenteric vessels. You see that the bowels are loose here, NG tube for decompression, antibiotics, and maintenance fluid. You see here also the stomach is visible, indicating that the defect is on the larger side and not narrow. And we tell the neonatologist not to bolus children, just maintenance fluid and no fluid bolus, because all that bolus goes in the bowel and then you have problems reducing that. So in a child as seen here, we would opt for primary closure. This is a typical patient. And then, of course, you can put a silo over. That would be very easy. But you can also, as seen here, put like a little retractors in the defect and then push the bowel in. And then what I do is I go with my finger inside the abdomen and enlarge the abdominal cavity, stretch the fascia a little bit to increase the abdominal domain, which is, of course, hypodeveloped due to the bowel that was outside the abdomen prenatally. And then you push everything in. And then at some point, you have all the bowel in. You see the defect is still very small. And that's very easy just to close it. And cosmetically, it is okay and will heal nicely. That's another case with some bowel loops that are not so super easy to reduce. You can also put in a silo in this patient and reduce primarily in the NICU. Of course, there's some cost coming with a spring-loaded silo, but if you can afford it, that's also a nice trick not to enlarge the fascia, but use the silo to reduce it and then remove it right away and close the abdomen. That's another case where you see, like in purple, is the colon that is severely enlarged. And that's in those cases, you can either milk it out, or what we do, we decompress it via in a large, like 24, 26 French irrigation tube. And as you all know, the meconium is sterile, so that's no problem to irrigate that colon out. That's another case where the colon is enlarged. You can, of course, imagine it's difficult to reduce that enlarged colon, which is full of meconium. And after you have irrigated the colon out, all the stool is evacuated. It's very simple to close the abdomen. This is the same trick to enlarge the abdominal cavity by stretching the fascia. And then again, it's very easy to close, and there's no much pressure in the abdomen if you decompress the bowel towards the NG tube and towards below. This is if you smoothen or milk the bowel out. Looks a little disgusting. I like the sort of cleaner way with the irrigation tube better, but that equally works. For all patients, I put a vac dressing on there just to keep the wound nice, dry and clean, and you don't have to look at the wound every day for 3 to 5 days. So what is better? Is the primary reduction better than the silo? There is one randomized controlled trial from Toronto showing that for parenteral nutrition, days in the hospital, incidence of NEC, that's no difference. A fewer days on the ventilator. For in the left column, you see the Celastic spring-loaded silo with 3 days is less than 5 days with the primary closure. However, this is a non-significant difference, but you may argue, Nigel will tell you that maybe, that you can earlier extubate the children. Apart from the randomized controlled trial from Toronto, there's another trial from Kansas City, published 2019, but also showing that the outcome is the same compared to the silo. Of note, in that Kansas City trial, there were 2 patients who had bowel ischemia and necrosis following the silo placement. So I would argue that maybe the silo caused that bowel perforation. We all don't know, but I think there is a finding that is at least worth mentioning. And there is a meta-analysis from Seattle showing that the primary closure actually had the improved outcome if all those studies were included in the meta-analysis that were analyzed. However, the authors then had a subgroup of studies with least selection bias, and in that subgroup, the silo was superior in terms of reduction of ventilated days, less time to first feeds, less infection rates. But I don't know, I was not really happy with that meta-analysis, because if you include studies with a selection bias, then all the outcome is different. So I put a big question mark behind that meta-analysis. We can discuss that. And this is actually the biggest multi-center retrospective trial, including 566 neonates from 7 US centers, also comparing primary reduction versus silo and showing that there is no difference. However, if you have a silo for more than 5 days, it indicates that there is a more severe disease with a less favorable course. There's always the argument against primary closure that the pressures in the abdomen are very high. However, there are also clinical indicators that you can use looking out for that abdominal compartment syndrome. For example, if the intragastric or intravesical in the bladder pressure is over 20 millimeter mercury, or the central venous pressure is over 4 millimeter mercury, that indicates that the bowel may be injured or getting pressure. Or if your respiration pressures are below 25 centimeter, then the risk of abdominal compartment syndrome is low. So those are the numbers you should look out for managing these children. So there are challenges ahead. That's why I don't like the silo for uncomplicated gastroschisis, because you see the defect actually gets larger with a silo, and you may face some cellulitis. By the way, this is, but Nigel will talk about the techniques, how to reduce the bowel. You see there is a ratex on the silo because there is loss of fluid via the open abdomen. That's another downside of the silo. And talking about the enlargement of the defect, for example, in this case, there was a 960 gram baby after 9 days. That's a really significant defect you create for such a small baby. And then you have problems closing it. This is a term baby after 5 days, after 4 days, also a very large defect. If you have cases like this with a small defect and a mass, obviously you cannot put a silo on. This case, we performed a laparotomy and then reduced the bowel into that abdomen, used also again a silo, that's an Alexis port, to reduce that in the abdomen to keep the incision small, and then remove it. We close the abdomen and then it needs to be muted. And then 6 weeks later, we relapsed that child, found jejunal atresia and fixed it. So obviously this is again not a case suitable for silo. What I'm always very concerned about is that a narrow defect is maybe too narrow, and then you put a silo in, and then you have hypoperfused bowel within the silo. And that's another downside why I don't like it for the primary reducible bowel. So taken together, why I opt against the silo and for primary closure is that with the silo, you have potential risk for bowel ischemia within the silo. You have an open abdomen, potential cellulitis, fluid loss. You have a temporary enlargement of the defect, and it's a multiple stage procedure. Versus the primary closure can be performed in the NICU under mild sedation, analgesia. There is no silo-related morbidity, obviously. It's the same outcome in 2 randomized controlled trials and 1 meta-analysis compared to the silo. It's a one-step procedure, and if that failed, you can still go for the silo. So I think taken together, simple gastroschisis, I think should undergo simple treatment. I know Nigel will maybe not follow the red line, but will take you through all these, curves and the complicated treatment of a silo treatment. But as you all know, the people from Great Britain, they're really smart. This is a map on the average IQ of the European population per country. Germany, as you can see here, is not just 99, but from the island, it's over 100. So I'm curious how Nigel will present his talk, but I'm sure he has pretty good arguments for the silo. Thank you very much for your attention.
Thank you, Martin. This was great, provocative. I'm glad to see that also Italy is above 100, and I think also Switzerland. But this is it was really very. You had great images, and now we are going to hear the other presenter of the day, which is Professor, or I should say Mr. Nigel Hall, as they like to be called, the surgeons like to be called in the UK. Again, Nigel needs no presentation or introduction. He's first of all a friend. He's been serving on the executive board of EUPSA for a number of years. He's the chair of the network office. Nigel is a graduate of the University of Cambridge in England, and is trained in the UK, but also here at the Kids in Toronto in 2013-2014, went back to England to hold then a position as a consultant pediatric surgeon at the Southampton Hospital. Is also an associate professor of pediatric surgery at the University of Southampton. Nigel has a lot of interests in different fields of neonatal and pediatric surgery. We all know his work on, for instance, pyloromyotomies and necrotizing enterocolitis. But I think what his main contribution is in our field is with regards to studies, randomized controlled trials, and trying to bring the evidence to pediatric surgery. So he was the leader of the China study on interval appendectomies, is now doing more studies on trying again to bring more evidence to what to do with congenital lung lesions. Today we are talking about gastroschisis, and this is also an area where he did some research, and I think we did also something together.
And now it's moved on?
It does, yes.
Fine, okay. So Augusto, thank you very much for that kind introduction. Martin, thank you for your talk on primary closure, and welcome everybody to this, as Augusto said at the beginning, one of a series of EUPSA webinars that are keeping us going through the lockdown. And I hope I can try and explain to you today our approach here for the treatment of gastroschisis using a silo. So I'm going to just talk to you about what we do, as Martin alluded to, a little bit of the comparative evidence between the approaches. So if we just go back, if you like, to the principles of gastroschisis and what we're trying to achieve, I think they're summarized quite well on this slide of what we want to achieve as surgeons during that first period when the baby, who's usually had a prenatal diagnosis of gastroschisis, is born. And there are some key things that we want to do over the next few days with the bowel, which is to protect it, return it to the abdomen, and essentially not to cause any harm. And also then to get the abdominal wall defect closed. And to try and keep the baby as stable as possible during those phases. And there's no doubt that primary closure provides an option for this. I'm not trying to suggest that it's a completely unacceptable thing to do, because it's clearly not. It provides a rapid solution, and it certainly meets the principles that one needs to consider and try and adhere to when managing these babies. But I think equally it's important to consider that it's not always achievable. There are some babies in whom returning all of the bowel to the abdomen is just not possible because the volume of abdominal contents outside the abdomen is too great. There are some babies in whom there's concern that the pressure that results in the abdomen once the bowel is back inside and the baby is, and the abdominal wall is closed, that the pressure may just be too high. And therefore it's not suitable for all babies. I think there are also significant logistical resource use, and in fact, other disadvantages that do have the potential to cause morbidity, and are probably, in my view, generally underrepresented in the literature about this, which is that primary closure typically requires a general anesthesia and a trip to the operating room. And those are things that I think we should be aiming to avoid in treating babies unless we absolutely have to. Primary closure often also involves doing an operation in the middle of the night, and we're all familiar with the concept that most babies with gastroschisis, for whatever reason, anywhere in the world, are usually born in the middle of the night. And of course, if you're going to close a babe with primary closure and you achieve a high intra-abdominal pressure, then there is almost certainly going to be a requirement for post-operative ventilation. And because of some of these aspects, amongst others, people came up with this concept of using a silo to close the abdominal contents and to gradually return the abdominal organs to the abdominal cavity. And we're all probably familiar with this picture on the left of what's being called a surgical silo. This was in the days when primary closure was attempted, that it was impossible to achieve, the defect had been widened, and a handmade or so-called surgical silo was placed on the abdominal wall that was gradually reduced over days. And the other thing I don't like about this baby is that it's got a Hickman line in, which also means it's been to the operating room to have an operation to put that in, but that's just an aside. And really then around, I think the first reports of this preformed silo came in the late 90s, early 2000s, when people developed this way of having a spring-loaded or a preformed silastic silo, which would really allow a way of containing the bowel, enabling it to be manipulated, enabling it to return to the abdominal cavity slowly with gravity, with a bit of, over a period of time, a lesser increase in abdominal pressure, and try to remove some of the problems that were associated with trying to achieve a primary closure. And that's been implemented in various places around the world. And there's no doubt that this silo, where it's been used, has absolutely revolutionized the treatment of gastroschisis. It's an incredibly versatile device, and I'll come on to a bit about that in a while. It can be done at the cot side. The baby doesn't have to go to the operating room. It can be done on the neonatal unit in the baby's cot. It doesn't require an anesthetic. You don't need to ventilate the baby at all. You can achieve the stage reduction with you can avoid a staging, a reduction without unacceptably high intra-abdominal pressure. And in fact, as Martin and Fennis alluded to, you can use this as a means to control the bowel and achieve essentially a primary closure without a general anesthetic in selected cases, if the bowel can be returned using this device relatively quickly to the abdominal cavity. There are a couple of different devices on the market around the world, but the principles around them are all the same. So what I'm going to talk about really is how we do it here in Southampton. And in particular, what we've learned about doing it. And there are some little tricks that I think are important, particularly when it comes to trying to avoid some of the complications or the potential complications that you might achieve. I'll show you a bit of data about our outcomes, and as Martin has alluded to, a little bit of the literature about it, accepting that there really isn't a huge amount of comparative literature out there. So this is how we do it. We aim to get the silo on relatively soon after birth. We always get IV access, give a fluid bolus, put a nasogastric tube in, do it at the baby's cot side, keep the baby warm, and we give the baby sucrose to essentially pacify it, but we don't give any significant sedation, and we don't give any anesthetic. And the first stage really is inspecting the bowel to look for the atresias, figure out what's eviscerated, see if there are any adhesions, and also make sure the edge of the defect is clear. I entirely agree that this is something that needs a bit of planning and setting up for, and there's no doubt that in your institutions you will develop an experience for doing this, and I would recommend you do it with at least 3 people. It needs someone to look after the baby, and it needs 2 people to examine and manipulate and control the bowel. Sometimes you find that other things are interesting. So the picture on the right here, you can see the bladder is very full and distended. So you might want to consider putting in a urinary catheter. And the other thing I would say that we always do in these babies, just shown in this picture here, is keep the umbilical cord really quite long, because we'll come back to what we're going to use that for later. So I mentioned about just checking the edge of the defect is clear. Sometimes you find these curious little adhesions between the edge of the defect that cross over either onto the mesentery, onto the bowel. And you need to deal with those if you're going to get a preformed silo into this baby. And there are a couple of options for this. So here you see one such defect that's got a band from the edge of the defect here across to the bowel. And what we've tended to do with these is either divide them with ties and then cut them, or use diathermy, bipolar diathermy, just to divide those, again, with the baby awake on the neonatal unit. We prepare our preformed silo. These come in different sizes. Most babies can take a size 4 or 5. They come in smaller and bigger sizes. We very, very rarely use a 3 because it really does make the stalk of the column of the bowel that you get in the silo very narrow at the bottom. And I agree with Martin entirely that one of the challenges and risks of this is of bowel ischemia and poor perfusion. And you really want to avoid narrowing the bottom of the defect as much as possible. So I wouldn't use a 3 unless you absolutely have to. Similarly, the bigger silos are only good in big babies. You really need to have quite a big defect and a lot of bowel eviscerated to justify using a bigger silo such as a size 6. And the number, by the way, refers to the diameter of the spring-loaded circle in centimeters. As it says here, definitely consider doing a washout to try and empty the colon, and definitely consider doing a urinary catheter, particularly if you see a distended bladder that's eviscerating through the defect. You want as much space in this abdominal cavity as you can achieve, so it's worth making all the efforts you can to try and make what's in the abdominal cavity as small as possible. This is the silo we use, made by a company called Medicina. As I say, there are other examples. The one used, I think, largely in North America is made by a company called Bentec, and it actually has a spring of metal within this silastic ring. This doesn't. This is just a silastic ring that pops open by itself. As I say, they come in different sizes. The number up here changes with the different size, and the number refers to the diameter across this ring on the right-hand side here in centimeters. So as I say, the stages to applying it, it takes several people. I would recommend that you lubricate the inside of the silo first, just by swishing some sterile saline around and having several people to put it on. You then need to identify the apex of the loop of eviscerated bowel and the bit that's got the longest loop of mesentery on it, because that's going to go into your silo first. And you gently insert the bowel into the silo. I'm asking your nurse who's looking after the baby to regularly aspirate on the nasogastric tube to make sure the baby doesn't aspirate. And as I say, we're now doing this without any sedation or anesthesia. We just give a bit of sucrose orally to the babies, and they tolerate this really well. So this is just putting that apex of the bowel loop into the silo and then gradually manipulating the silo down. You have to concertina it down rather than be able to push the bowel high up into it. And eventually you're left with this as a column. And I would recommend that you don't pull this tight upwards, because you don't want to lift the bowel off the baby. You just want to achieve a sort of neutral balance that allows the bowel to go back in under its own steam. So once you've got the silo on, it then becomes to how you go about reducing it. And I'm quite a fan of trying to achieve what you can pretty much immediately. There are some of these babies, and this baby in the picture here, in fact, is one of them, where you can see that the abdomen really looks really empty, and there's plenty of space in this child's abdomen. And it's actually possible in most cases to get a reasonable proportion of the bowel that's out back in pretty much straight away. And I would recommend you try and achieve that. You don't want to increase the pressure too much. You don't want to make the baby uncomfortable, but you can usually get at least half of the bowel back in straight away. If you can reduce it straight away, then by all means go ahead and just use this silo as a way of achieving a primary closure, but without needing to go to the operating room or having an anesthetic. But if you can't achieve that, then aim to do it relatively quickly. And I would advise trying to do it over the next 2 to 3 days. And the reason for that is partly, as Martin says, that the bowel does secrete a fair amount of fluid, and we do recommend replacing that fluid whilst the bowel's out to try and keep up with the insensible losses. But also because the longer this preformed silo is in, what happens is the defect at the umbilicus tends to stretch a little. And what you don't want to run into is challenges with the defect getting bigger and bigger, and therefore becoming harder and harder to close when the time comes to close it. We don't routinely use any antibiotics for these children while this is going on or happening. Some of these babies are placed on antibiotics because of concerns around perinatal sepsis, but just because they've got gastroschisis, we don't use antibiotics. But we have noticed that if you measure their CRP over time with the preformed silo 1, it does tend gradually to rise, and we don't get concerned about this. And we've actually published that so that people are aware of it. And hopefully what you achieve is that gradually over time, you can reduce the bowel into the abdominal cavity. These ties that you see here, they come with the preformed silo. And so what you can do is you can use your fingers to manipulate the bowel down, and then you place a tie above the bowel to stop it popping back out again. And once the bowel is flat on the abdominal cavity, sometimes it's not possible to get it completely flat, but once it's pretty much flat, then the time comes to consider the closure. And when it comes to considering the closure, obviously there are two choices. We are of the thought that if you're trying not to give the child an anesthetic to place the silo 1 in the first place or do a primary closure, then we're quite attracted to the concept of doing a cot-side sutureless closure at the bedside without sutures. But as Martin has explained, you can always take the baby to the operating room to do a standard sutured closure should you so wish. So a cot-side sutured closure, again, looks like starting with the baby once the abdominal cavity is pretty flat. And again, you need 2 or 3 people for this job, because when you take this silo off, the bowel sometimes has a tendency to try and pop out again. Again, we give the baby sucrose to pacify them, but we don't give formal sedation or analgesia. And you need someone to be holding the bowel in with a gauze when you take the silo off, and somebody to be drying the area around, because you want this nice and dry and adhesive so that you can put a dressing on it that's not going to come off. And we tend to prepare it with a sponge, and this has got some solution on that dries the skin out and then makes it good for placing an adhesion on. And then essentially the process is that one person holds one side of the baby's abdomen and the other holds the other side, and essentially pulls this umbilical cord all the way across and tucks the other in. So you're essentially achieving a vertical midline closure at muscle and skin level, but using this long cord for traction. And that's why we leave the cord in. And we also try and keep the cord moist whilst the silo's on, trying to make sure that it stays as healthy as possible to help in this part of the process. And essentially we close this with some robust steri strips, a series of these. We place an absorbent dressing on the top and we leave it for a week. And after that, we take the silo off and they've all closed beautifully. Occasionally you have one that's a little bit open and we just continue to dress that, and the epithelialization of that happens with granulization tissue, and they don't go on to cause any trouble. So some things we've learned along the way, and I entirely agree with Martin about this point. Keep watching the bowel, okay? Just because it's in a silo doesn't mean that it's going to be perfused or stay healthy. There have been some reports, and we've had experience of when you put it in the bowel, there's inadvertently a kink being made in the mesentery or in the bowel, and concern about the perfusion to the bowel. And my advice would be, if you're at all worried about the bowel, just take the silo off, check it out, and you can always just replace it back in the same silo and put it back on again once you're happy. But have a really low threshold for doing that if you are going to use one of these silos. This isn't a just put it in and wait for gravity to take place. This is actually some active management required, both to reduce it, but also to keep a close eye on it. And I really would aim to reduce the bowel as soon as you can, ideally within 2 or 3 days, 4 at the most, but a real maximum to 7. And in that picture I think Martin showed of 9 days later, that's the problem. You have a really big abdominal wall defect if you leave the silo on for a long period of time. And it then becomes really hard to close by either sutured or sutureless closure. Sometimes we found the defect is really very small, and you don't want to put a size 3 on for the reasons, as I mentioned, of pinching the blood supply at the abdominal wall level and making the bowel ischemic. And so what we've learned to do is that you can enlarge the defect and still place a preformed silo. And you can still do that at the bedside with the baby awake. So we inject some local anesthesia and either cut it or use the diathermy, bipolar diathermy, to enlarge the ring, and you can still place a preformed silo. We've noticed equally when you do that, that also tends to mean that the defect stretches a little bit quicker. somehow interfering with that natural ring that's there, even though it's not closed. Once you interrupt that, seems to mean that it does stretch. So if we're going to do the defect enlargement, I'd aim to get everything closed even quicker, and consider whether primary sutureless closure is still going to be an option at that stage, or whether it's better to take the child to the operating room for a sutured closure. We've also learned you can operate on the bowel and still use a preformed silo. And the small number in the series of babies we've treated have had an anastomosis for an atresia or something else wrong with the bowel, and then it's actually been placed in this preformed silo because it couldn't be completely returned to the abdominal cavity. A primary closure wasn't possible, and we've managed to successfully manage them with these preformed silos, having done surgery on the bowel. So they're pretty versatile things. So our experience, I just thought I'd put out some data. We've been planning to treat most babies, or all babies really, with a preformed silo for the last 16, 17 years here. So we've had 215 babies with gastroschisis in that period. 3 of those have died during the neonatal period, 1 from sepsis, 1 from congenital anomalies, and 1 from NEC after the abdominal wall was closed. But most of them have done very well. And I just pulled out the data on the babies who've had a preformed silo. During that time, some babies have had a primary closure. So they'll be the ones that we think really can just go back in and we've closed primarily. But in the 185 with a preformed silo, we've managed to get the silo on, the abdominal wall contents reduced, and the abdominal wall closed in nearly 70% of those without ever ventilating any of them. And I think this represents a real advantage of this technique. I appreciate that neonatal care is pretty advanced in many countries, but if you don't need to ventilate a baby or give an anesthetic, then I think it's probably in the baby's best interest to avoid that. In terms of other outcomes, longer term, things like length of stay, duration of parenteral nutrition, and overall survival, I really don't think there's a huge difference with these techniques. I think they're pretty comparable. I think the main difference is in the utility of the device, the need to go to the operating room in the middle of the night, and the benefit of not having to intubate, ventilate these babies or give them a general anesthetic. When we look in the literature, as Martin alluded to, there's pretty much not a huge amount of comparative research comparing these techniques. When you read these papers, you just got to be careful whether they're actually talking about primary closure or silo closure, rather than talking about just the technique used to close the abdominal wall at the end. And there's a difference between those. Disappointingly, Martin didn't cite my own systematic review and Augusto's. He found another one, but there we are. So as Martin said, little actually clinically difference in many of these outcomes in terms of duration of PN, length of stay, but definitely fewer days on a ventilator with the silo. And I personally think that's a real benefit. There's also just this very large study of over 1,000 babies with gastroschisis, and they did a analysis of these two, and essentially their conclusions were in the middle of this slide. So they reckon that if you have simple gastroschisis, then the benefits of silo reduction outweigh any drawbacks in terms of multiple procedures, albeit with not an anesthetic, and possibly less ventilation time. But if you've got complicated gastroschisis, then primary reduction appears more feasible. But little comparative research, and I'm not going to sit here and say definitely I think one is way better than the other, but I think there are certainly advantages to the silo closure that you can take some care of. It's a versatile tool. I can't emphasize enough the need to monitor the bowel carefully. I would plan to reduce it relatively quickly, but I don't think there's a huge difference in length of stay or duration of PN with these techniques. Thank you.
Thank you very much, Nigel. This was a great overview of your technique, your approach. I want to kick off with a question right away. You had a table, one of the last slides of your presentation, where you had the primary closure and the silo, preformed silo closure. you didn't have p-values. I gather there were no differences between the two groups. It was like, in terms of length of stay, was like 32 and 36 days.
Yeah.
And that was not significant.
Indeed.
Right. And another question that I have, and this is for both of you, he came up with Nigel, but this is I think we don't have any evidence to say what is the best approach. What do you do if you see a baby that has an intestinal atresia right away when you are examining the bowel for the first time? Do you just close it, or you put it into a silo and then you close the bowel and then you wait to see whether the baby then develops an obstruction, and you study that baby a couple of weeks, 2 or 3 weeks later, and then you bring that baby to the OR? Or do you instead do take the child to the operating room right away, and you try to fix the bowel? Or do you do an investigation right away? This is just baby's just born, comes to you, and you're assessing the bowel, and you are querying an intestinal atresia.
Who do you want to go first?
I don't mind. So what we do, we usually reduce the bowel in the abdomen first and then come back 4 to 6 weeks later. Okay. We would not necessarily put out a stoma, because then you have this stoma morbidity. And of course, surgical options, I think, are reversed for cases where the bowel is really floppy. But if there's a lot of inflammation and thickened bowel, obviously that's not the time when you want to be aggressive. I can remember we once had a case with an atresia, maybe 1 centimeter left of the TI. So we brought out the appendix as a stoma and then refed stool through the appendix in the colon, and then went back six weeks later. But I think it's a question on philosophy. Some people fix the atresia right away, but we usually don't. Nigel?
Yeah, so I agree. I don't think there's a right option here. For me, the quality of the bowel is quite important in this situation. So as Martin says, if you've got nice, healthy, floppy bowel, there's, as you've seen just the pictures today, some of the bowel is really not covered in any what's called a peel, and it's not matted together. It's really loose and pliable. It essentially looks like the sort of bowel you'd find when you did a neonatal laparotomy. If it's a baby like that and it's a healthy term baby, I'd certainly consider repairing the atresia primarily and trying to get a primary closure. And if I couldn't get a primary closure, actually I'd do that on the surface of the bowel and consider putting a preformed silo on afterwards, aiming to try and get the anastomosis inside the abdominal cavity, but using the rest of the bowel in the preformed silo. I think if there's any matting or you're worried about the distal bowel in any way, then I agree. I would plan to just put on a preformed silo, go down our usual route of management, get the abdominal wall closed, and then go back in and investigate and repair the atresia at a later stage. All right.
So there's quite a few questions. First, Dirk from Delft is asking a couple of questions. One is regarding feeding strategies for patients that have the silo. Do you consider enterally feeding the babies while the silo is in place, Nigel? And the second question is about the sepsis rates in both units as related to gastroschisis patients.
So feeding wise, the answer is we typically don't have that problem, because we aim to get this silo closed and the abdominal wall closed really quickly, within 2, 3, 4 days. And there are very few babies with gastroschisis who are actually ready to tolerate enteral feeds at that point in time. So it's very rarely a problem. We have occasionally had a baby who's had to have it on for a longer period of time for some reason, and they typically aren't ready to tolerate any enteral feeds at that stage when they've got their silo out. So we don't, but it's not because philosophically I think it's a bad idea, but just typically because the babies aren't ready to feed enterally at the time when they have their silo on. Sepsis rate, I don't know if that question's about sort of things like systemic sepsis and line-related sepsis or surgical site infections. So one thing that we do in babies with the silo is that we make a decision fairly early on about the timing of central catheter placement in relation to the abdominal wall closure. And what we're doing is that if we think we're going to get this silo closed within 2 or 3 days, we actually delay placing our central line, and we never use Hickman lines in these babies. We always use neonatal long lines. We delay placing our central line until after the abdominal wall is closed. And that was because we suspect that there's a degree of translocation that happens whilst you're manipulating this silo back in. And so what we've noticed taking that approach is that seems to reduce the incidence of sepsis in these babies.
Martin, what are the sepsis rates in your?
Yeah, well, I totally agree with Nigel. There's usually no sepsis like within the abdominal cavity, even with a silo being on there for 4 days to 1 week. The sepsis comes with the central line, and we also place like a pig line, like a spaghetti, these long lines. And my observation over time is that it depends on the NICU also. There are really NICU teams that like super good, super sterile, and the lines almost never get infected. And there are NICUs where you have an infection every other day that you have to treat them. And regarding the feeding, I think it depends on how much inflammation there is. If it's floppy bowel, you may want to start, you may be possible to start early because the gastric residuals, the bilious is not so much. But if there's inflammation, then there's no chance to feed the child. But there are also other options, like with my foundation, we are in Ethiopia a lot. And there's no TPN, so there's no other choice than to feed the baby. And if the baby tolerates that, has a chance to live. And if the baby is not tolerating feed, just dies. So sometimes you don't have any option.
Right. A question from me, Tool from Bangladesh. Does any one of you use the umbilical cord flap to cover the gap after reduction?
Nigel?
Yes. Yeah, so sometimes when you've reduced the bowel, if you can't do that technique that I showed you the slides of, managing to approximate the edges of the muscle and skin together, if you really can't achieve that, then I have occasionally used the umbilical cord to plug the gap. And essentially what I've done, I think there's a technique that came from Brisbane, is coil up the umbilical cord and essentially make a coil of it that fills the defect at the skin level and place a big adhesive dressing on the top with a bit of a pressure dressing on top of that. And that's worked quite well in the couple of cases I've had it. I think it's quite nice to try and get the muscle as close together as you can to try and make any residual abdominal umbilical defect that there may be as small as possible. But it's certainly a possibility. And that's another reason for keeping the cord long and healthy.
Okay, Nigel, may I ask you one question? You mentioned you have to keep the cord moist. So there is no role for a vac, right? Because this would be like the ideal indication to place like a vac with a white sponge, but then it gets pretty dry. So that wouldn't work? Yeah,
so I'm sorry, I'm talking about why the silo is on.
Well, I was talking about your sutureless closure technique.
Yeah, no, we don't necessarily keep it moist for that part, no. It needs to keep moist and alive while the silo is on.
So a white sponge vac would work?
It may do, yeah. But I'm not sure it's necessary.
I can tell you from my experience. I think that Nigel and I have a similar training experience, and so we do things in a similar way. But I happened to cover for colleagues who were then away, and the baby had a silo and was ready to be closed, and they didn't really care of keeping the cord moist. And it's more difficult when you do a cot side closure. It's always nicer and easier to pull that cord, to use it, and then that cord will fall off. And then of course we always get called by the nurses at the bedside that there's some infection of the wound, and it's never a real infection. It's just how it looks like when the cord folds off by itself. So Sandra Montadonico is asking, have you seen any differences in the need for silo in term babies compared to preterm babies?
I mean, I think that's difficult to answer because our standard approach is to use a silo for everyone, is the honest answer. But certainly, if you've got a preterm baby who needs ventilating with respiratory distress and you don't want to increase the abdominal pressure by pushing all the contents back in quickly, then using a silo is a really good option for those babies in particular, because you can gradually return the abdominal contents to the abdomen and then close it a couple of days later, and they tolerate that really well.
Derek is asking, going back to the question of when to feed these babies. This is for both of you. What are your endpoints for ready to feed? When do you start feeding these babies?
Okay,
so we do. I'm sorry. You go.
No, you go ahead.
So it's the gastric residuals and how bilious it is. As you all know, it's getting lighter first and then less NG drainage. And then what we do is we start like when it's at least less than 10 cc per kick per shift, which is like almost still a lot. And then when you feel that the child is ready, which is like usually not before 1 to 2 weeks, all the inflammation is down, then we start with either continuously 1 cc per hour, or you can connect the NG tube with a syringe, which is open, and then just feed into that syringe, and by gravity, it runs in the child, or if the child is not ready, it will elevate the fluid level in that syringe. And then we go super slowly. And if you do it continuously, when you're 5 cc per hour, you can go to bolus feeds. That's what we do.
Yeah, we use a similar approach. There's no real difference. We're guided by the residuals. We put it on what we call gastric elevated free drainage. And when the baby's showing signs that it's ready to tolerate milk into the stomach, we start. And we try and start pretty early, to be honest, even if there's still some bile coming up. We're quite speculative with starting a bit of feed quite early, because often the feed seems to sort of kickstart the GI system into working.
Right. So trophic feeding is always fine.
Yeah. And I also often give some rectal glycerin suppositories just to try and stimulate the baby passing stool as well, because I think that probably helps a little bit.
Oh, well, that Nigel, that reminds me of, if a child is really not ready for a long time and you're concerned of TPN injuring the liver, then you can actually feed rectally. We have done that in the past also. It's a little disgusting thought in the beginning, but you can actually take like hyper-elementary feeding and then go continuously through the rectum. I don't know, Nigel, have you tried that?
So we've not done it recently. I know one of my colleagues used to do it about 40 years ago, called nutritive enemas, but it definitely, there's definitely a role in it for some babies, I'm sure, but we haven't done it recently.
Okay, let me find some questions one after the other, and you answer quickly because we are already over the hour. But there's still quite a lot of interest in the topic. So Nigel, again to you. Alison Campbell says, so if you don't place a line till the baby has a silo closed, maybe 4 or 5 days, that means that they're not meeting the BUPS guidelines regarding parenteral nutrition. Yeah,
so there are these guidelines for parenteral nutrition, so I think they're guidelines, and I agree that we're not necessarily meeting them in the first few days in these babies, but actually if that means that the risk of central line sepsis goes down, then I think it's the risk benefit profile is in favor of doing it. We only do that when it's sort of 2-3 days and we anticipate it's going to go in fairly quickly. If there's anything getting up to anything 5 days to a week, we just put the line in.
Okay, so Gareth, now what is with the muscle fascia in cases with the silo? Have you seen defects after removing the silo?
So yes, so some of the babies, when you take that dressing off after a week, there is a little bit where the fascial layer has not completely opposed and kept together. There's sometimes a bit of bowel, tiny knuckle of bowel visible, and over time we just keep dressing it, granulation tissue forms, and it epithelializes over just fine. it's really quite unusual, even in that situation, to end up with an umbilical hernia. Quite a lot of these babies have a curious thing. Can I share a screen with you, Augusto, just to show you one picture? So here you can see, I hope, that the babies have had this preform silo. They have quite a wide umbilicus, and it's flat. Now, if you push on it, there's no muscle and there's no really thick fascia there, but it doesn't bulge out like an umbilical hernia. But so they have this slightly curious wide and flat umbilicus, but there's no bulge there as such. So that's what they tend to look like, you know, when they're 2, 3, 4. We've had very, very few that we've needed to actually do any sort of what you might call umbilical hernia repair on. And actually the ones we've had are historic ones, and it seems to be just as high with primary sutured closure as it does with a silo sutureless closure.
Yeah, so I totally agree with Nigel, and there are several papers indicating that the incisional hernia rate after operative closure is actually higher compared to the sutureless.
I can tell you there's a paper that Ted Gestel was previously a surgeon here at Sick Kids, and now is the chief at Memorial Sloan Kettering in New York. He published on the plastic closure, where he says that actually following up these babies and when they are around 4 or 5 years of age, when we would consider an umbilical hernia repair, the need for that was actually they definitely presented with an umbilical hernia earlier, but it then closed spontaneously. Didn't need an operation. So that's something very interesting. Arnaud Bonnard from Paris asking, before staged reduction maneuver, are you giving a shot of analgesic medication? If yes, which one, considering that the patient is not intubated?
So we're just giving them sucrose. Occasionally they get some intravenous paracetamol, but nothing more. We used to give them a sedation, midazolam, and we found that there were more side effects from giving them a sedation than we thought there was benefit. And so we stopped. And so we just give them sucrose and paracetamol.
Great. Again, Mibdul, is it possible that the defect might close spontaneously after the eviscerated bowel is reduced, and we should give it a try for natural abdominal wall closure?
So I think it will do, yes. I think the challenge is if you don't try and bring those edges of the defect together, what happens is the pressure is too great. And so when you take the silo off, the bowel just pops out again, and it's impossible to control. So I think it's worth trying to get the edges of the defect together. But as I said, the ones where we take the dressing off a week later, if there's a tiny gap there, it does just epithelialize a bit like an exomphalos or omphalocele sac will epithelialize. And actually their long-term outcome is just as good.
And you really need those, and you really need those long steri strips, you almost do a parachute over it. And sometimes even you need some glue that it doesn't fall off. So the small steri strips, they wouldn't work.
This is actually, I was about to say, we used to do that when I trained at King's more than 10 years ago in London. We used Dermabond. And Dermabond is not really supposed to be used in this where you have mucosa, but it worked beautifully. And we I think reported it at BABS, but it was not. It never, I think, made it to a paper. But it's definitely working. Dirk makes a comment that they actually put the cord inside the belly when they use the silo, and this keeps it snug and moist. And they've used also vac cover, the vac over the coiled up cord after removal of the silo if the defect is big. This is a comment to what we were discussing before.
Nice trick.
What treatment for pain management after primary operative closure is asking Nekshmi Haiseni?
Well, I'm not really sure. I asked my neonatologist. Usually, I think paracetamol is just fine. But if the child obviously is in pain, you need some opioids. But we don't have a really strict protocol for that, to be honest.
Okay, Nigel, do you have any Any protocol post-closure?
No, we give them, after an operative closure, we give them all paracetamol regularly. I think that's really important. I think it's something that neonatal units are really bad at making sure happens. And we give them, typically most of these babies, we use a morphine infusion for that.
Okay, great. I think we have concluded this long list of questions. Definitely your presentations generated quite a lot of interest, and I think we always have, we learn, although we try to get an evidence-based approach to our practice in pediatric surgery, but it's learning actually from each other most of the times, that from our own mistakes on others' mistakes, how we also advance. So I don't know if Martin, do you have any other comments? Nigel,
thanks for Nigel's great talk and your moderation, and Gaia's great organization as usual. No other comments. Thanks for joining.
Well, thank you, Martin, Gaia, of course, and Nigel. Thanks everyone for joining us today. This will be posted eventually on our YouTube channel.